This is Metabolic Mastery, a KORR Medical Technologies podcast dedicated to advancing knowledge and practice in metabolic testing. Welcome to Metabolic Mastery, brought to you by KORR Medical Technologies. I'm Dr. Marc Humbert. This is Dr. Cameron Garber. Today we're going to be talking about BMI, some of the myths and misconceptions, where it's useful, where it's maybe not so useful. So we'll dive into all of that. But first, let's talk about what BMI is. So in technical terms, it's your body mass in kilograms divided by your height in meters squared. And so kind of an interesting history. It was developed by a Belgian mathematician. I could not pronounce his name, so I'm not going to even attempt it. But he was trying to find the height of the average man. And so he found that weight typically increases in proportion to height squared. So anyway, there's that. Here's the problem, though. He only looked at Western European men. So not a great metric for the average man.
For the whole world, right?
For the whole world, right? So in the 70s, it was repurposed by Ansel Keys. He's a physiologist, dietitian. If you've ever heard of the Minnesota starvation experiment, he was involved in that. So a lot of the foundational work in nutritional research was laid by Ansel Keys. And so he repurposed it for a measure of obesity and of mortality risk. And so it works pretty well from a population level, looking at those things, but not great for the individual. And so that kind of leads us into some of the uses and some of the problems with it. But first, I want to dive into kind of where Cameron developed his love-hate relationship with BMI. It's actually a really fascinating story. So let's
well, so it's funny because I get in this debate fairly often about BMI. I actually like BMI quite a bit, and people will bag on it, and I'm like, well, as long as you use it correctly, it's actually a great tool. We just don't use it correctly in most of healthcare. So here's my love-hate relationship with BMI and how that started. So I used to work at the University of Utah in their stroke rehab department. And so I moved to the outpatient stroke team and was kind of leading the charge on building up our outpatient stroke program. And one of the things that I would often do in working with folks who had a stroke was I would look at their BMI before they came in to know whether or not I would need additional help, if I needed a second set of hands, because if they had a really high BMI, sometimes it was harder to lift and move and manipulate depending on the level of their stroke and things like that, how impaired they were from the effects of the stroke. And so that was one of the metrics I'd often look at. And I was surprised at how often they didn't have a high BMI, but were there for a stroke. Because we think of stroke as a cardiovascular disease, which is typically related to overweight and obese and things like that. But so often the people I was working with actually didn't have a high BMI. And just on appearance, you wouldn't think they were at high risk for stroke. And so that combined with, I was tasked with creating a wellness program for our stroke program. And I was so frustrated by the fact that our wellness efforts were way too late after they'd already had a stroke, instead of preventing them from having the stroke in the first place. And I was trained during my physical therapy doctoral program, was trained by an amazing clinician, Julie Knighton, who was trained under Dr. Kenneth Cooper at the Cooper Clinic, who was like, he's the godfather of fitness research, if you will. He really did, that Cooper Clinic was foundational in exercise science research. And so I was kind of a step away from being trained under somebody that was trained under the original people. So I knew I had this skill and was like, yeah, that is something that I would love to be able to help more people prevent having a stroke in the first place. And that led to me leaving the university so that I could pursue that more directly. And BMI just was one of those things where I struggled with it at first, because I was like, that didn't help me at all to know why they had the stroke in the first place and things. But as I studied BMI more, it's actually a very useful tool. So I love it from the standpoint of, as a predictor of longevity, it can be very helpful. In a predictor of acute health or a metric of acute health, it's not very helpful at all. it can let us know about overall body mass, but whether that's fit mass or fat mass, we have no idea from BMI.
Yeah. Well, that is the kind of the major complaint, right?
Right.
Oh, it doesn't tell me anything about fatness. And that's absolutely true. But like you mentioned, it tells us from a population perspective about what are the risks for that person.
Right.
And that's kind of the difficulty with any population study is it's great at studying populations, doesn't always tell us
About the
about the
individual.
individual. But again, really, really useful still. And so when we look at the data on BMI and mortality risk, so death from any cause, we see this kind of J-shaped curve.
Right.
And so what that tells us is that on the low end of BMI, there's heightened risk. And then on the high end of BMI, there's heightened risk. And the risks go up even a little bit higher for the very high end. So that's hence the J shape. But in that middle level is where the lowest risk is.
Yeah.
And so understanding that can give us an idea of, oh, is this something that I need to look for, right? I'm classified as on the high end. I'm classified in that high risk category. How do I do a deeper dive and understand some of the things about those categories that will give me a better idea of, oh, am I really high risk, or are there some potential confounders? And so again, that takes us back to the limitations of BMI. So as you mentioned, not great at telling us body composition, right? It tells me my body mass, but not whether that's coming from fat or muscle or bone or whatever. It's not a great measure of fitness. And again, as you mentioned, it's not a great indicator of acute risk, right?
Right.
And so, and then some of the confounders, well, actually talk about some of the confounders that impact BMI on the low end and on the high end.
Yeah. So, I mean, I always say it's not a good measure of fitness, fatness, or am I healthy? At least acutely, right? But long term, it can be a pretty good predictor. So, the high end or at the low end, I guess, if we're very underweight is the current classification. So that's one of the things I hate the most is the way that things are classified. We use them as name calling instead of as a way of helping to direct health choices.
Yeah.
And so on the underweight side of things, it may not pick up everything. The fact that the reason why we're underweight is because of maybe a major health condition like cancer, or because we smoke and so we don't eat as much because of the smoking or things like that. So there can be on the underweight side of things underlying causes that have made us underweight that make us quite unhealthy. And then on the overweight side of things, we can have high muscle mass but actually be quite unfit. If we are quite overweight, we often will develop muscle mass because moving 400 pounds takes a lot of muscle to be able to do that. But it may not be high quality muscle that's very effective, efficient muscle. And so just because we're have a high muscle mass doesn't always mean that we're fit.
Yeah. No, such a great point. And one of the things that's often lost in the shuffle.
Right.
So you mentioned you don't really like those
the
labels.
Categories.
Yeah. Talk about why that's an issue for you, and maybe what's a different way, perhaps a better way to look at it.
Yeah. So the current categories kill me. Underweight, normal, which what does that mean?
I mean, you're not normal. I'm not normal.
I've never been normal. So overweight, obese, and morbidly obese are the main categories. And really, that just feels like name calling. That's not very helpful from a clinical standpoint of understanding where is this person's health at. And so, like we said, it's not a good measure of fatness. You can be a 27 BMI and be incredibly fit and have 10%, 12% body fat, even though you're a 27 BMI. And so not very helpful there in terms of a good fatness measure or body composition measure. And so the normal range is currently listed at 19 to 24.9. So I would argue that we need to restructure our categories. So that normal range, that doesn't fit what the science is telling us. Where people are most healthy is actually depending on the health condition. When we look at all-cause mortality or specific cause mortality, some things it's 20 to 21 at the low end. and other things it's 21 to 23 at the low end. But the sweet spot really is like 22 to 24, 25 is where people tend to live the very longest. People in their 24s actually have the longest lifespans, which is fascinating to me.
Yeah.
And so being of a higher body mass right on that overweight, category is actually the sweet spot for longevity. So we're better off being either slightly fat but fit, or just having a high fitness with high muscle mass is really the sweet spot. And that's going to help us live longer than anything else. And so being just skinny or having a low body mass, that's not helpful. And often leads to more problems. And so BMI is just one piece of the overall puzzle. But really the sweet spot in terms of all-cause mortality is 21 to 27. So we really should recategorize those things instead of calling us by names of underweight, overweight, obese, normal. Instead, it should be just risk stratification. You have average risk, you have low risk, you have high risk. Recategorizing those things by our risk levels would be much more helpful and much less hurtful in terms of helping us to actually make health decisions based on this information.
Yeah, and that's really where BMI shines, is that risk stratification.
Right.
And what you identified there, right, that kind of 21 to 27, that's what we were talking about earlier in that J-shaped curve. That's kind of that bottom part of lowest risk.
Right.
And so what we're finding,
and 23 to 25 is like the very bottom of that for most conditions.
Exactly. But what we're finding is, again, what you talk about is issues of not having enough muscle mass. And that becomes a huge problem at any age, but especially as we get older. The risk for falls after the age of 65 goes up pretty much exponentially. And so, we're talking more about sarcopenia, right? Low muscle mass. We're talking more about the dangers of not having that. And then as you also mentioned, having poor cardiovascular fitness. If we don't have good muscle mass and if we don't have good cardiovascular fitness, our risk for everything goes up.
Right.
And aerobic training and strength training actually decreases that risk. So there's a great article authored by Sue Phillips. It's called The Coming Age of Resistance Exercise as a primary marker of health or something like that. But it looks at decrease in risk if you do aerobic alone, if you do strength training alone, and then combined. And the effects are synergistic such that, like, combined, they have a bigger effect than
either of them alone.
Exactly. And so really profound. And so that leads us to what you said earlier, is sometimes people that are overweight have more muscle mass, but it's not always the healthiest muscle. And so having a high quality of muscle becomes really important for staying healthy, for staying active, and warding off a lot of the diseases of age. And as you and I have talked about so many times, so many of the things that we associate with so many diseases of aging are not really diseases of aging so much, but diseases of low activity.
Right. Yeah. Well, and so I think when looking at health, some of the most important metrics are cardiovascular fitness. That's why we do VO2 testing, why that's so important. And then our muscle mass, right? So those two things, cardiovascular fitness. And we see this all the time of people who are very, very fit, like bodybuilder types, but then have really poor cardiovascular fitness. Or we see people who are thin, but are actually quite fat inside. And so, or very unfit. And so either one, they're going to be unhealthy. So we have to make sure that we're monitoring all aspects of our muscle quality and muscle health, including our cardiovascular health. Our ability to deliver energy to those muscles well is an important part of health and healthy aging.
Absolutely. So let's dive into some of those factors in muscle quality. The first one is what we call fat infiltration. It's also called IMAT, intramuscular or intermuscular fat, some people use, but it's this idea that fat has surrounded the muscle in an unhealthy way.
Yeah, it looks like a marbled steak.
It does, but that's
Yeah,
such a good way to look at it, because we often don't think of it that way. But that's really unhealthy for the muscle. So not only does the fat impair muscle function, so you have a reduction in what we call specific force. So your cross-sectional area, how much force can that produce? And when you have muscle fibers that are surrounded by fat in that same area versus just muscle fibers, you have a lot less ability to produce force. So it makes it harder to move, impacts your strength. But um, that uh, fat infiltration, it's not an inert tissue. By that I mean it has effects. It doesn't just sit there and clog things up. It actually acts as an endocrine organ, right? So endocrine organs can have local effects, they can have systemic effects. And so what happens with the fat that's deposited in an unhealthy way around these muscles is that it affects your insulin sensitivity, which means that when your body releases insulin, it's harder to pull that into cells to use it for energy. It impacts your mitochondrial function, which is huge for being able to process and
so
use
important.
energy,
Yeah,
and thereby it impacts your ability to oxidize fat. And so the fat that's surrounding your muscle, it makes it harder to use that muscle for energy. And so it impacts two things, what we call fat flux. And so that is just fat moving in and out of the cell, right? How's it being mobilized? How is it being utilized? How's it being stored? And is it moving often in and out of the cell, or is it just sitting there? And then metabolic flexibility. So metabolic flexibility is really your ability to optimize which energy source you're using and quickly switch between fats and carbohydrates, depending on the activity, depending on the intensity, depending on energy demands. And so that is this huge problem, and we often don't think of that. And so what we'll see sometimes in some of the measures of how much muscle do I have, if we're not visualizing the muscle, we can overestimate how much muscle we actually have, or we can overestimate the quality of that tissue.
right.
And so there's some techniques, right? If we're just doing a circumferential measurement of the muscle, even things like DEXA only get us part of the way there. They don't have enough resolution to look into the actual muscle, the fat that's in the muscle. And so things like
Not always. Yeah.
MRI, yep. So MRI, CT, ultrasound can actually visualize the more of the muscle at a higher resolution, so we can see like, hey, what's the quality of that tissue?
Yeah, so I used to do caliper measurements when I first started because it was cheap, it was easy to do, and the problem with caliper measurements is again that's only looking at adipose tissue, like subcutaneous adipose tissue, basically, right?
Yeah.
And so that doesn't tell the whole story. That doesn't tell about visceral fat. It doesn't tell about the fatty infiltration into the muscle, and so it often left a lot to be desired in terms of, is this somebody trending upward or downward in their fitness, right? If you take two people that, if this one is getting more fit and this one is getting less fit, there's a point at which they may cross over from if you did a DEXA scan, they would look fairly similar. But the person who's trending upward in their fitness, if you took their labs and other things, are actually going to look much more healthy in terms of their lab work and their overall health status because of those healthy behaviors that they're participating in. Whereas this person, as they're getting less fit, those healthy behaviors are actually, they're in a catabolic state of breaking things down, while this person's in an anabolic state of breaking things or building things up. And so all of the different health consequences of that are going to be more positive if we're in that build up, healthy behaviors state.
Yeah, that's such a great point. And really the question to ask ourselves is, am I living the lifestyle? Am I developing the habits of a healthy and a fit person? Or
Right.
am I living the lifestyle, developing the health habits of an unfit and unhealthy person? And just what you mentioned, you can look really fit and healthy, but be on that negative trajectory. And you can look rather unfit and rather unhealthy, but be on that positive trajectory and beginning to develop habits that are going to have a huge impact on quality of life, on muscle function, on aerobic function. And
Yeah.
so really important thing. So another thing that we often don't pay attention to is the muscles themselves, right? What's happening at the muscle fiber level, and what's happening with the nervous system and how that interacts with the muscle. I think those are really important things. And so one of the things that happens as we age is, so we have two main categories of muscle fiber: our slow twitch and our fast twitch. There, we go so deep, but for purpose of this discussion, we'll say fast twitch and slow twitch. And so the slow twitch fibers are more involved in kind of activities of daily living, right? I'm walking, I'm doing laundry. Those are much more active.
Postural support, things
Exactly.
like that. The boring stuff.
The boring stuff, right? But as a result of using them so often, those tend to be preserved much better over time than those type 2 fibers. The type 2 fibers being the ones that are responsible for kind of high force, high power, right? I have a lot of strength and I can use it quickly. And so because we tend not to do activities like that, like we stop running, we stop jumping. Cameron always loves to ask people the question.
Two questions. One, when was the last time you remember running? And then when was the last time you remember jumping? And it's often sad.
Yeah.
Those responses, people will tell, often with running, it's a specific story. One lady was telling me about how she remembers being at Green Pond, which there's a trail up in the mountains by the ski resort. But she remembers they were on the trail near Green Pond, and her daughter started running away from her at like 3 years old. So she would have been in her late 20s, maybe early to mid 30s. Her daughter started running away from her, and she started to chase her daughter, and her knee hurt. And so she caught her daughter, and she didn't jump in the lake or anything. But her thought to herself was, oh man, I should stop running. My knees really hurt. And so she never ran again from that day. And so I met her in her early 80s, and we got her jumping and running and doing things again. She's like, man, I wish I had have met you then. Now I would have known that I just needed to start running more, just at the level that my body could tolerate it. Sprinting to go save your kid was maybe more than your body was ready for because you hadn't done it in so long. But she remembered. It's often a thing where people can remember the last time they ran and decided I shouldn't run anymore, or jumped and decided, ooh, I shouldn't jump anymore. And that's sad, because we should still be able to run and jump.
Absolutely. Well, and it so much impacts our quality of life. And what can I do? Can I travel? Can I live the life that I expected to live at this age? And so often the answer is not really.
Yeah.
But that's the beauty of this, is that there's so much we can do about it, right? Doing things to improve our muscle health, our cardiovascular health. And even if we miss the boat and we're now 80 or beyond, like there's still so much we can do to improve.
And you can get it back.
You can get it back. Yeah. And so that's the cool thing. And so going back to what happens with the muscle fibers is these fibers that are involved in running, jumping, more high intensity activities, they begin to atrophy, their shape changes, and so they're not as effective. But with strength training, we can reverse a lot of those changes, slow them down, and get back some of that speed, some of that power, and actually begin to change the shape of our muscle cells again, so that they can function in the way that we want them to.
Yeah.
And it also improves our nervous system's ability to fire those muscles, right? It's not enough to just have muscle mass. We need to have a good connection with our nervous system so that they can activate what we call motor units. So it's a bundle of muscle fibers, and the nerve that innervates those is a motor unit. And so that's one of the things too, is with disuse and with being sedentary, those neural connections get weaker. And so doing regular strength training to improve that can have really profound effects. Because what you mentioned, like sometimes people are cardiovascularly fit, but they have low muscle mass.
Right.
And so
really common among runners.
Absolutely. And so it just stresses the importance of having both things. Both is really important. And then really talking about the aerobic capacity of muscle is talked before with the fat, right? We decrease our mitochondrial density, our mitochondrial function. And so we need not just the strength training to help with the structural characteristics of the muscle fibers, but we need aerobic training to get better at feeding those muscle fibers.
Yeah, fueling it.
Exactly.
Yeah, the cardiovascular work works on the systems that fuel those muscles, and then the strength training obviously builds up those muscles. So it's, improving our fuel efficiency as well as building up the size of the motor.
Absolutely.
To use an analogy.
Yeah, exactly. And so I can't stress this enough. We need both muscle and aerobic capacity. I know this probably feels like beating a dead horse, but it's such a foundational principle.
So I always tell my runners, your next most important workout is your next lift, not your next run. The thing that's going to make the biggest difference in your running is your next lift, not your next run. And I always tell my folks that prefer lifting to cardio, I always tell them your next most important workout is your next cardio session. Your next zone 2 slow, boring cardio session is probably the most important thing you can do to take the next step in your training. And so it's finding that balance. If we can fuel our muscles well, and keep getting energy to them, we can see really great results in our strength training. If we can keep our muscles strong and develop a lot of power out of them, it's going to really improve our running or cycling or whatever cardio we love to do. But making sure you have that balance is super important. That's why we do both the VO2 max testing, right? And our metabolism testing to make sure that those systems are tuned up and that we're doing the right things there for their body at this moment. And it's also why we really emphasize strength training and getting the right types of exercises for whatever activity they're trying to train for, the specificity of training. But making sure we have both of those things is so critical. And that's why that is such a crucial, the VO2 testing is such a crucial element in our programming is it will allow us to hit both of those things.
Absolutely. And it really goes back to that idea of lifespan versus health span, right?
Yes.
We all want to live a long time, but how do I want to live during that time? And,
Right.
and both strength training and aerobic training are going to increase that health span, right? The period of time at which I'm really healthy and I can stay active and my body isn't telling me no.
Right. So we want to dive into that in our next episode, into the squaring of our longevity curve, right? But essentially, I always say strength training is the fountain of youth. That's how we feel younger and maintain our capacity and all of those things. And aerobic training is the key to longevity. If we want to live longer and keep our heart healthy and keep delivering that energy to those muscles, that's where cardiovascular training comes in. And together, that's really where we see the ability to increase our longevity, is doing both strength training and cardiovascular work.
Absolutely.
Anyway.
So no, great points. So let's dive in now so we've talked about
back to BMI.
Back to BMI. So we've talked about what BMI is,
yeah,
and where it's useful, and we've established that really as a way to stratify risk. Am I low risk? Am I medium risk? Am I high risk? But we talked about how it's not great at measuring fitness, and it's not great at measuring fatness. So let's talk about some of the other metrics that we can use that actually do look at those things and give us a more complete picture of our overall health. So let's dive in first to what's maybe better at measuring fatness.
Yeah. So fitness, fatness, and acute health.
Mm-hmm.
So fatness, DEXA scan is going to be a really great way to get a good look at body composition. Really, really good. Bioelectrical impedance analysis. There are some tools now that give pretty good, pretty accurate measures of body composition. So great tool there. Calipers is a cheap one. Like I said, there are some limitations there. BodPod was a great technology when it first came out. Still helpful. Maybe not quite as accurate as DEXA and things like that. A little cumbersome, but not too bad, and gives you really accurate information in terms of body fat composition. Body fat distribution is another important metric to really look at. As we talked about earlier, the composition where you have more belly fat is going to be more of a risk. So looking at, if you want another inexpensive way of looking at that, there's the bioelectrical impedance analysis. There's handheld ones that are fairly cheap that get you within a ballpark. And then the hip to waist ratio, height to waist ratio. The bioelectrical impedance isn't going to give you as much distribution information. But the hip to waist ratio, height to waist ratio, and caliper measurements can actually give you a little bit more information relative to where that body mass is located.
Yeah. One, so women in this regard are kind of lucky. So women tend to store fat more in their buns, hips, and thighs. And so less of that central fat.
Adiposity
Yep, adiposity. Yep.
that men have, yeah.
So men tend to be at higher risk because we tend to store more belly fat, and that actually ends up being really dangerous. So when our body fat is concentrated, around our midsection and especially in and around our organs, that's when it has these huge metabolic risks. And becomes much more dangerous. And so again, that waist to hip, waist to height ratio does a really good job of telling us, am I at higher risk for what we call, again, central adiposity, but it's just that increased visceral fat around the organs.
Yeah.
Yeah.
And the reason to look at both waist to hip and waist to height is if your waist and your hips are both larger, and so it may not tell you as much as looking at both waist to hip and waist to height at the same time.
Yeah.
So one may not be as indicative as the other. So anyway,
No,
but yeah, both are helpful in terms of measuring fitness. Honestly, the best way to measure fitness is VO2 max testing. Really such a great way of knowing where somebody's fitness level is at. It doesn't always, like we've talked about before, tell us about performance. And so there are other things that we can do to measure performance as well. But in terms of just a good snapshot of how fit is this person, what is their fitness capacity, VO2 max is awesome. And then it also allows us the opportunity to look at substrate utilization so we can get a better look into their metabolic health.
Yeah.
So the one caveat with BMI and fatness and things like that is you're better off being fat but fit.
Mm-hmm.
When someone has a high BMI, even if they have a high body fat percentage, they're at a lower risk than often people who are skinny, a low BMI, or a quote unquote normal BMI, but are unfit. We lovingly call those folks skinny fat. Being skinny fat is actually much higher of a risk than being fat but fit.
Absolutely. So you look into a lot of the research over the years, even some in the 80s. So there was a paper by Blair in 89, Ortega, I think 2006, maybe that was 2016. Wheel Dryer just came out with a big one, 2024, 2025, but it's looking at those exact categories, right? Am I overweight and unfit versus normal weight am I overweight and fit versus underweight and non-fit? And you see people that are like very overweight but have the highest fitness level have a lowered risk than people that are normal weight but in the lowest fitness level. And so huge impacts. And so if we're working on improving our cardiovascular health, that's going to have so much bang for its buck. Even if we're not seeing like weight on the scale drop a ton, we are going to see our blood work, our risk factors, all these things improve with regular cardiovascular exercise. And so this is such a huge point to understand, I think.
Well, and the reason why I like using VO2 testing to help people engage more in cardiovascular training is that it lowers the barrier of entry. When we find out for their body, what's the right way for them to be training right now? In terms of dialing in that zone 2, knowing where their zones 4 and 5 are, things like that, and avoiding zone 3, it makes it so much more precise. People feel better because they're not in zone 3 so much, and it increases compliance when people feel better, enjoy it, and aren't beat up. And that's the key, is compliance. If they can be consistent with it, they're more likely to see results and they're more likely to stick with it.
Yeah. Well, tell me the story you were telling me yesterday of your father-in-law's friend. You remember that?
Oh, well, yeah, he was blaming running. That it always kills me a little bit, because and this is very, very common. I hear this all the time, where people blame the activity and not the way they were doing the activity. Where he's telling me how he can't run anymore and some other things because his knees hurt and his back hurts and this and that and the other. When really it's everything that he was doing was high intensity work. Or moderate intensity work, not high intensity work. And so he was always feeling beat up from it because he wasn't able to do the low intensity work to build a base and the high intensity work to improve his fitness. He was always just in the middle and always felt beat up and worn out from it.
Yeah. And so it's really tells us, how is my body at recovering, right? And am I doing too much of the moderate intensity? As we've talked about in previous episodes, the results of that type of test can tell us a lot about the type of training that person is doing.
Yeah.
And so can just yield some really valuable and actionable insights for training and for health. I want to dive back into what you talked about with substrate with VO2 max,
Yeah.
because this goes back to that idea of metabolic flexibility. Can I easily switch between fuel sources, and as we train in that way, right, to get more efficient, it helps us to be more metabolically flexible. So VO2 max, right, again, important, has a really good correlation with longevity, and it really kind of tells us the capacity, right, the size of the engine. So I can have a big engine, but it might not be very fuel efficient. And so I'm not going to get very far. And so looking at that substrate data really gives me an idea of what's my fuel efficiency. And just fat is kind of a cleaner fuel source, if you will. And so if I can use fat at a wider range of heart rates, then it's going to be easier for my body to recover in between sessions. It's going to be less load. And so I can progressively increase my capacity without overreaching too far. And so that ends up being really important data to understand.
Right. And it really is a great metric of capacity increase. Have I put in the work to increase the capacity so that I can function at a much higher level, but it feels for my body like it's easier.
Yeah.
And so I love being able to look at that increase in essentially fat burn, increase in RER as the heart rate climbs. If we can keep our RER, or respiratory exchange ratio, or essentially the ratio of fat to carbohydrate, if I can burn fat higher into my heart rate range, it means that I've improved the muscle function, the delivery systems, and all of those things, so that the same amount of work that I'm doing is requiring less feeling of intensity for my body. It's able to keep up in that slow burn phase better, if that makes sense. So so being able to look at somebody's metabolic health like that, we also look at the resting metabolic rate as well as a way of tuning into somebody's metabolic health, so that we can look at extreme lows, extreme highs, and see where people's metabolic rates are, so that we can help dial in their nutrition and understand better where they're at, so we can see, have they been starving themselves to try to lose weight? Have they been under fueling for their sport, or things like that? That really can help us dial in for that individual what type of decisions we should be making. And that's the key with BMI, with any metric at all. We should focus more on metrics that help us make decisions. And so that, I feel like VO2 testing is really helpful at leading towards making decisions for our health instead.
Absolutely. Just a really great tool in the toolkit to understand really a lot about your body's health.
So much. Yeah.
And about your potential. And like you said, does it tell me where I need to go? And I think that's really useful. Can we use metrics that give us not only an idea of where we're at, but that are going to give us an idea of where we need to go and how do I get there?
Yeah.
That's really important. So one more thing that I want to add in that we didn't talk about earlier is one of the things that we see sometimes in people with low body fat and high muscle mass is androgenic anabolic steroid use. And
yes.
that actually has a really big impact on mortality risk. So those, so regular steroid users have a much higher risk for mortality than the average population.
Right.
And so, like, they might be really high body mass, right? You can even see body mass of 30 plus with people using those type of steroids. And so we've talked about how having a lot of muscle and having good muscle quality is important for longevity, but that's looking at it from a perspective of, have I built that muscle naturally? You might be really fit and healthy for a period of time. I would still argue you're not living healthfully when you're using that regularly. But you might have more muscle mass that protects you from certain things for a period of time. But the risks of use definitely outweigh the benefits.
Yeah.
And falsely kind of falsely elevate the benefits of having large muscle mass.
Right. We didn't hit on that strongly enough. Why do people hate BMI so much?
Yeah.
Right. And a big part of that is, well, I'm fit, but this says I'm fat. And like we talked about, it's not a good measure of fatness. But people will bring up NFL players or bodybuilders or things like that. And that's why Marc brings up the anabolic steroid stuff is, yeah, bodybuilders they're quite fit and they do have low body fat percentage with a high muscle mass. They also tend not to make it into their 60s. Most bodybuilders tend to die at a fairly young age because a lot of those activities that they're doing to get that high of mass is very hard to sustain, for one. and 2 is hard on your body. So are there natural bodybuilders who can do it without steroids, without performance enhancing drugs? Sure, there are a few. They're very few and far between. And they still don't tend necessarily to have a long lifespan, partially because it's very hard to maintain that throughout a lifespan. And so if you're used to eating a certain way and used to having a high BMI, so essentially the lifestyle that keeps you at a high BMI, and then those lifestyle factors change, but your diet stays relatively similar, and you're kind of used to being, I would hear this all the time in the clinic. I hear this quite a bit, is the I'm a big guy. This idea that because I'm 6'2", 6'3", 6'5", that I'm just a big guy. And so it's natural for me to also be over fat. That doesn't necessarily have to be the case, but because they're big guys, they tend to play those big guy roles in sports and other things, and they never tend to detrain from that. And so having a high BMI, the reason why that's such a high risk is the lifestyle factors that go along with that tend to be hard to detrain. Even if you have a high BMI and a low body fat percentage, it's hard to detrain from that and go back to eating less, moving more, those types of behaviors that bring you back to a more moderate BMI. That is going to be something that, for longevity's sake, is going to keep you healthier. And so we find that people over time, even when they're in their 20s, 30s, 40s, that have a high BMI but a low body fat percentage, tend not to maintain that through their 50s, 60s, 70s.
And so
so that becomes a risk.
Yeah.
I guess.
And so exactly. It becomes a risk. And so we don't want to make the distinction of like having a lot of muscle mass is bad, because again, we can't overstate the importance of having enough muscle mass as we age.
Right.
It really goes back to sustainability and understanding that there is no one best exercise program to select for everything.
Right.
So the best program for hypertrophy is not necessarily the best program for longevity.
Right.
And that plays in so many different things. And so what can I sustain over years, right? What's doable on repeat again and again? And what also keeps me from being injured?
Right.
I think we see that a lot, especially in athletes, is it's like they are so high performance. They're awesome at what they can do, right? They've really pushed the peak of what humans can accomplish. But they end up just kind of destroying their bodies for things. And
Right.
they get injured again and again and again, which makes it hard to go back and do the things, right? Oh, I keep getting injured. Why am I going to run? Why am I going to do this? Right.
Well, so NFL players are a great example of again, a population of people that don't make it to Medicare age. They typically pass away before they're of that age. And so kind of crazy to think that extremely fit people, but that doesn't necessarily mean healthy. When you look at it, so a lot of insurance companies will use BMI, and people are like, oh, my insurance denied me because my BMI was too high, but I'm super fit. I lift weights and all this stuff. It's like, okay, I get that. But if you're looking at it from an insurance company standpoint, an NFL player, the average NFL player has multiple surgeries a year. That's expensive. To be able to maintain high body mass and a low body fat percentage to the point that you're above that, like 21 to 27. So the 27 allows for a lot more increase in muscle mass. But if you're outside that 27 and still have a low body fat percentage, the activities that you're doing to maintain that are decreasing your longevity, because they're high enough risk in terms of injury and other breakdown and problems that you're having multiple surgeries. Not maybe a year like the NFL players is fairly extreme, but there are other confounding factors that decrease your longevity. And so that's why we say that within like 21 to 27, you're probably pretty safe. Outside of that, it starts to become a risk, even if you have a low body fat percentage.
Absolutely.
And so, and again, when we're looking at it from a population standpoint, individuals obviously can be somewhat different, but it's a good thing to check yourself with and be cognizant of, like, do I have so much mass that it's not sustainable, that it's not something that I'll be able to do long term, things like that.
Yeah. So those are really great questions, right? Is it sustainable? And am I moving in the direction of things that are going to keep me living not only longer, but living better longer?
Hmm.
And so selecting for that. And so there is just so much disagreement, so much argument in the health and fitness realm, people talking about past each other. And a lot of that is people with different goals and different timelines, again, talking past each other. And so what we're talking about here is, how do I reduce my risk over time? And how do I live a really long, healthy life?
Yeah.
And doing that requires that, again, we retain enough muscle mass so that we can function well later into life, and that we have really good aerobic capacity. Our heart and our lungs are healthy, so that they can sustain all the activities that we want to do. And if we want to do that, then life's going to look a certain way. And again, BMI, for all of its faults, right? We've talked about how it isn't a good measure of fitness. It's not a good measure of fatness. It's not a great measure of how am I doing acutely, but it does work really well, again, for that risk stratification. Am I low risk? Am I moderate risk? Or sorry, am I low risk? Am I moderate risk? Or am I high risk? And then being able to make decisions based on that. And do I need to change my training? Do I need to change some of those lifestyle factors
Right.
so that I can make this sustainable?
Well, and the key is using BMI with a bunch of other tools so that we can make decisions that affect lifestyle.
Absolutely. Absolutely. Well,
Yeah.
awesome. Any last nuggets of wisdom to add?
I think that's good. I'm sure I could keep going.
We filled it up.
Yeah.
Well, awesome. Thanks so much for joining us today. As always, remember to like, follow, and subscribe for more of this content, and we'll see you next time. This podcast is a production of KORR Medical Technologies. Ready to take your metabolic testing to the next level? Visit KORR.com to learn more about purchasing our metabolic test equipment.